Sounds good.
All right, well, we are just a few seconds past 7, so I guess we'll get started. Good morning, everyone. It is my distinct pleasure to introduce our speaker this morning, Dr. Gabe Arguelles. He is one of the BNI residents who's been with us for the past 3 months. Gabe did his undergraduate studies at Washington University in St. Louis and his medical school at the University of Pennsylvania. And when he joined us, he had a clear interest in spine, which won't surprise you as that's today's topic, but we've done our best to try to bring him over to the ped side and have him show him a good rotation. So, Gabe, thank you very much for all your hard work over the past few months, and we look forward to your talk today.
Thanks for that introduction, Dr. Bristol. I've had a really good time learning a lot on this rotation, so I appreciate it. It's been a very warm welcome, and I've enjoyed working with all of you. Um, so, jump into it here. Today, I'm going to talk about traumatic injuries specifically at the craniovertebral junction. We won't really go into the subaxial spine too much, so that's below C2. We're going to keep it from occiput to C2 for the most part. And we probably won't really talk about too much etiology other than just traumatic ones. There are other etiologies of craniovertebral junction, especially in pediatrics, syndromic, congenital, and the like. We'll go into it a little bit, but I think with the time we have allotted, focus on traumatic injuries. Feel free to interrupt me whenever to ask questions. I don't mind at all. All right, so I'm going to mute my phone. So first, we're just going to go over the anatomy of the craniovertebral junction. I think it's absolutely essential to get a better idea of this pretty complex anatomy here compared to the rest of the spine and different parts of the body, as it really informs how we think about injuries in this area, stability in this area, different injuries to different parts can mean for the patient. So here, just a couple of images showing that complex ligamentous structure with a lot of different moving parts, really anchored by the axis, the atlas, the clivus, the foramen magnum. So we'll kind of go over them one by one, and then following that, we'll go into kind of some of the injuries we can see in children. So this first slide, we're just going to talk about the occipital bone, kind of the top of our discussion today, the superior aspect of the craniovertebral junction. First, I guess, learning point is that the occipital bone not only includes what we all think about, the back of the skull, but also the clivus that forms part of the occipital bone. And two important landmarks whenever we think about craniovertebral junction in pediatrics are going to be the anterior aspect of the foramen magnum and then the posterior aspect of the foramen magnum. These are important landmarks for radiographic imaging, CT imaging, and MRIs. And measurements using these landmarks can sometimes give us some insight as to different injuries we can see in these areas. So the opistheon is the posterior aspect of the foramen magnum, kind of the inferior most extent of the subocciput as it meets the foramen magnum there, and that's kind of that image in the middle. On the right, the Bayesian is the bottom part of the clivus, the inferior most aspect of that bone, of that part of the occipital bone. And then on the left, you can see kind of a bottom-up view of the occipital bone, which kind of gives us some previews of some other parts of the occipital bone we'll kind of discuss in the second slide, but you can see the occipital condyles coming into view there, as well as the condylar canal, some different bony protuberances there that are given names, not all of which we'll discuss in detail today, but here on the second slide, we'll kind of round out our discussion of the occipital bone. So we'll talk about the first part of the craniovertebral junction that's going to be involved in the joints that we'll be discussing, and that's one of which is the occipital condyle. So those are the articulate part of the articulating faces of the OC1 junction. It arises from the bottom of the occipital bone. On the left, you can see kind of a nice labeled anatomy of that region. And what I want to highlight here really is that there are a lot of cranial nerves in the vicinity of the foramen magnum of the craniovertebral junction, which really become important when there are traumatic or other injuries to this region because you can see cranial nerve palsies. So on the left upper image, you can kind of see the occipital condyle going away from us, kind of as the foramen magnum comes into view there. And then just superior to that is the jugular tubercle, which is just a bony prominence kind of between the occipital condyle and the hypoglossal canal and jugular foramen, which are highlighted more superiorly here. On this image on the bottom here, you can actually see the hypoglossal canal highlighted. That's gonna, obviously house the hypoglossal nerve. Um, or cranial nerve 12. And just superior to that, you can see the jugular tubercle, which is that bony prominence we talked about. You see the jugular foramen, which has cranial nerves 9, 10, and 11 running through them, and then see some other structures here. On the right, you can see a nice coronal image, which highlights this anatomy in a slightly different view. And this area of the condyle with the tubercle and the hypoglossal canal has been said to resemble an eagle's beak. So you can kind of see that resemblance there. But here you really see nicely the OC1 joint articulation. So this is going to be the cervical one level. This is the condyle right here. This kind of notch formed by the jugular tubercle is going to be the hypoglossal canal where cranial nerve 12 is. So you can really see the intimate relationship with the condyle and the cranial vertebral junction of the hypoglossal canal. And that's kind of the main learning point of this slide. And here's a nice overview as well, a little more zoomed out view of that anatomy. All right, and then we'll kind of talk about our first joint here. So the AO joint or the atlanto-occipital joint, also called the OC1 joint. So this is the joint formed by the junction of the occipital bone and the atlas or the cervical one vertebral level. On the top left, you see some of the anatomy of the actual interfacing, the interface of the joint itself. The main learning point for this part here is just looking at the concave and convex relationship between the condyle, which is going to be convex, and the C1 superior articulating facet, just superior to the lateral mass of C1, which is going to be concave. And that comes into view when comparing, contrasting this level with the C1, C2 articulating the C1, C2 joint because they're very different. And that has some implications on their predisposition for injuries, their stability, and so forth. So when talking about the AO joint with this convex concave relationship, that does give it a lot of stability. And as a consequence, it limits mobility of this joint. You can see that there is some kind of translational movement that is afforded to it by this shape and relationship. But really, what we see at this joint is flexion and extension. And more or less, there's ranges in the literature about how much you see of flexion and extension at this level, but 25 degrees is a good kind of middle ground of how much your typical patient can flex and extend from just this joint. Um, and on the bottom left image, you just see the relationship again with those convex and concave faces of the joint. You see that they're The C1 SAP or superior articulating surface is angled medially and superiorly, and that kind of acts to prevent axial rotation at this joint as well. So these things are all kind of important with regard to the function of the joint. And then the last thing, a couple things we'll talk about on this slide is that on the right, the highlighted ligaments just are to highlight those ligaments that are intimately involved in the actual joint itself. And that might not be immediately obvious from the location of the ligaments themselves, but these ligaments often extend more laterally than we think about in images. So that, for example, the posterior OA or occipital atlantomembrane, it doesn't look like it's intimately involved with the joint there at the C1 cross-sectional image you see. However, it does extend more laterally and does kind of drape over that joint and is important for its stability, as well as the anterior OA membrane and the tectorial membrane. And we'll kind of go over those membranes individually, but just to give you an idea of what's kind of the key players here at the AO joint. And the last thing is the top right of the screen, which can show you one of the conclusions of one of the papers by a pediatric neurosurgeon, Dr. Brockmeyer, which I'll kind of quote different at different points in this lecture. He did a finite element analysis of the relative contributions of different ligaments to stability at the OC and C1-2 joint. And I didn't know what finite element analysis was prior to this talk, and but just an overview. It's a computational tool that simulates biomechanical behaviors by breaking these complex moving parts into simpler structures, and it's a mathematical tool basically that gives us some idea of the relative contributions to stability. And from that paper, he found that the actual capsule itself, and there's ligaments intimately associated with the capsule, are very important and the most important when thinking about the stability at the AO joint, as opposed to some of the named ligaments we think about, like the tectorial membrane, like the transverse ligament, and so forth. So the capsular ligaments he found are actually the most important at this level. In the atlantoaxial joint, so the C1-2 joint, we see pretty big differences compared to the OC1 joint. So on the left, the shape again becomes important. Here, instead of the concave-convex relationship, we see a concave-concave relationship between the C1 and the C2 vertebral levels. That comes at the expense of stability, but you do get a lot of motion from that. So it's kind of a benefits and cons to that concave convex relationship. It's pretty unstable, but you get a lot of axial rotation around the dens or the odontoid process of C2, and that's what everyone kind of thinks about when you think about the atlantoaxial joint. But kind of a lesser known part of this is you do flex and extend a decent amount at the C1-2 joint as well. And that kind of becomes more clear when you look at that relationship of the joint shape. The other part to talk about here is that this joint is actually composed of three joints. There's the medial anterior AA joint, which is a pivot type synovial joint, where C2's dens kind of rotates around the ligaments and the C1 level. And then there's the lateral joints at each side, where the dens articulates with C1 as well. Now, going back to that finite element analysis on the top right, the conclusions for the C1-2 joint are that the major stabilizers were the capsular ligaments again, but this time also some ligaments extrinsic to the capsule itself. So the transverse ligament and the integrity of the dens were also found to be the one, two, and third most kind of important things as far as stability, where if they're incompetent, the joint is unable to be stable at that level. And you have to think about some more definitive internal fixation for this patient. So this is kind of a summary slide for this first part and a synthesis of a few different studies. Again, there's a lot of ranges of different planes of motion between OC1 and C1-2. These are just kind of some middle ground numbers to make it a little simpler to interpret. So the AO joint and the AA joint and flexion and extension actually both contribute quite a bit. The AO joint contributes a little bit more, and that's consistently been found in a few different studies, but the AA joint is not far behind. So you see 25 to 20 kind of degrees of flexion and extension afforded by each joint. The middle section just shows us the axial rotation. This is a big difference between these two joints. So with that convex shape of the C1-2 joint, you see a lot more axial rotation there. Actually, 60% of our axial rotation total that comes from our ability to move our neck and our head comes from this joint. The AO joint has almost no ability to axially rotate. Lateral flexion does not really come from these two joints. It comes from the subaxial spine and the facet joints at those levels. And the last thing to mention here, this is kind of the more famous study down here by um, Punjabi et al. It's kind of an old study from 1988, but it just shows a cadaveric study where they applied a fixed force to these levels to measure their different range of motion. So they measure their neutral zone where the ligaments are kind of in relaxed and their elastic zone where these ligaments start to tense up and the muscular tenses up. And then the range of motion, which is the addition of these two things. And these are just terminologies that are used frequently in kind of range of motion literature. You'll see that these numbers don't perfectly correlate with my table, but there have been some studies subsequent to this that kind of added more insight as well. So I think a good quote that sums up the differences in these two joints is from neurosurgeon from India, Dr. Atul Goel, who's either the former or the current JNS Spine chairman of the editorial board, most known to me, I don't know about in general, but for the Goel Harms technique for atlantoaxial fusion. He kind of was quoted in a response to one of these papers saying, in the craniovertebral junction, the atlantoaxial joint is the center for mobility, and the OA joint is the center for stability. So I think that's a good way to remember it. So now we'll just go in briefly to talk about the actual different ligaments involved. And I think from this part of the talk, you'll get a better appreciation for what's really important structurally. Because I guess to preface, we get a lot of patients with varying degrees of sprain, edema in these ligaments, and can become a little difficult to understand how to manage these patients if it's not a clear-cut dislocation um, at the an OA dislocation at these levels where these ligaments are all torn, and that becomes clear that this patient needs definitive management. But in this kind of middle of the spectrum where we see most of our patients with some level of sprain, it becomes important to see the relative contribution of strength of these ligaments to figure out what's best for this patient. If they're able to just be kind of um, externally held in place with like a cervical collar, rigid orthosis, or if they need internal fixation. So the first part is the anterior and posterior AO and AA membranes. These are not very integral to the stability overall of the craniovertebral junction. Um, the anterior AO and AA membranes are extension of the ALL or the anterior longitudinal ligament that we're more familiar with in the rest of the spine. We frequently see this disrupted in different pathologies and fractures, and they don't automatically mean this patient needs to go to the operating room to get internally fixated. And then the posterior AO and AA membrane are extension of the ligamentum flavum, and you can kind of see that nicely here. So again, these two are not super, super important for stability, but they're part of it. In contrast to that, the alar ligaments are very important to the structural integrity of this part of the spine. So these ligaments arise from the anterolateral aspect of the dens, as you can see in these images, and they attach to the medial aspect of the occipital condyles, inferior to the foramen magnum. Their primary function is to restrict motion. And if you think about the joints moving in axial rotation, you can kind of picture in your mind that the contralateral alar ligament is going to be tensing up when you're turning, let's say to the right, the left alar ligament is going to be tensing up. So it's really the contralateral alar ligament that's restricting axial rotation. And a similar kind of thought process goes for lateral flexion. And then the bottom right image is a nice view of what you can see on MRI, especially in a coronal plane for these patients. You can pretty nicely view the alar ligament up here, arising from the dens and inserting here into the medial aspect of the occipital condyle. The transverse ligament is what's pictured more inferiorly, and that's part of the cruciate ligamentous complex that we'll discuss here in a bit. So here's the cruciform, or also called cruciate ligamentous complex. That's comprised of both longitudinal and transverse components. So first we'll talk about the longitudinal band. That is not the important part of the cruciate ligament when it comes to stability. The much more important part for stability is the transverse ligament, which we'll talk about next. But to briefly go over this one, it, oh, sorry, one second. It arises from the posterior aspect of C2 and inserts up on the clivus. There's a part that goes superiorly and a part that goes inferiorly, as you can see in this image here. And then going horizontally on this cruciate ligamentous complex, we see the transverse band. That's the one of the strongest, if not the strongest, craniovertebral junction ligament. By some people think it's the most important ligament in the body overall, given that its disruption can really be consequential for patients' neurologic function, depending on what's going on with regard to compression of the spinal cord. But this is really what holds the dens in place, and it prevents the dens inflection from impinging on the medulla or the cervical medullary junction and that area. So you can see that it inserts at C1 at the medial tubercles of C1, and it wraps behind the dens. So it keeps the dens in very close relationship with the anterior arch of C1. And on the right-hand view, you can see the atlantodental interval, or the interval between the posterior aspect of the anterior arch of C1 and the anterior aspect of the dens, is an important radiographic parameter when looking at whether or not the transverse ligament is ruptured. In kids, there are various kind of numbers as to what's normal because kids have more ligamentous laxity than in adults, and we'll go over that. But less than 5 is generally considered as kind of normal for an ADI. On the top hand MRI image, you can see a nice depiction of this ligament. It's hypointense like the other ligaments are, and you can see that it's in articulations with the C1 medial tubercle are intact, and there's no kind of bright stir signal or T2 signal there. The tectorial membrane is kind of our last important, quote unquote, important membrane for stability at the craniovertebral junction. It's a major stabilizer. It's the continuation of the PLL that we know about in the rest of the spine. It inserts up by the clivus. It actually becomes continuous with the dura at that level. And then it inserts inferiorly at the posterior aspect of C2. Whenever the tectorial membrane is incompetent or ruptured, it can range from a variety of kind of things. It can go from just being stripped off the clivus to being ruptured entirely. If it's stripped off the clivus, you can often see a retroclival epidural hematoma, and that's kind of one thing that's associated with AOD, or AO dislocation. And here's a nice depiction of that on the bottom left. Next is the apical ligament. Some strong contrast with the last one we just talked about, an important tectorial ligament. The apical ligament is really thought of as a vestigial structure. It's actually absent in about a fifth of cadavers in one study. So it's not really thought to contribute much as far as structural importance to the craniovertebral junction. Fun fact is the area on top of the dens, between the dens and the base of the clivus, is called the apical cave. It's an area that's really well visualized on MRI. It holds adipose tissue, and it holds the apical ligament, and it's housed by, like, posteriorly, the superior aspect of the cruciform ligament, and then anteriorly you can see the AO membranes there. This is a nice kind of summary table from one paper that goes over and ranks kind of these membranes and ligaments as far as their contribution to stability. None of this is clear cut, obviously. This is just kind of to give us a qualitative understanding of what might be the more important things to look for when kids have injuries to these levels and what that might mean for what we need to do for treatment. So the tectoral membrane, the alar ligament, and the cruciate ligament, as far as especially the transverse component of that, are kind of the three more important ligaments in this area, as well as, not pictured here, the capsular ligaments. And that's, if you remember from that finite element analysis, found to be really, really important. And here you just see some other components that some of which we spoke about, some of which we did not. For example, the nuchal ligament, which we didn't talk about. There are some other things that are less important for stability. There's also the musculature of the craniocervical junction, which deserves mention, that contributes stability, but again, kind of less so, and contributes stability in summation with all the muscles together contribute stability instead of one muscle individually. All right, so now we're going to talk about traumatic injuries. So this is an abnormal CT scan, obviously, and we'll talk about why that might be in a little bit and what that might mean for the patient. But this is kind of the meat of this talk, so we can see how these patients present and with what. So first, the epidemiology, just briefly. Um, Craniovertebral junction injury, or really cervical spine injuries in general, represent 1 to 2% of all traumatic injuries in children less than 18 years of age. 60 to 80% of all spinal trauma is going to be located in the neck or in the cervical spine. And we'll talk about the reasons for that. Here's one really nice paper that goes over, it was a retrospective review at a level one trauma center, a large level one trauma center, 12-year kind of single institution experience, patients 16 years of age and younger, all of which who were diagnosed with a cervical spine injury of some sort, and kind of went into the different reasons or etiologies or mechanisms, and then where that injury was. And important things to note here is that the majority of these injuries across age groups is going to be motor vehicle collisions or MVCs. That kind of is 50 to 60% of the reason these children present, unfortunately. On the right side of your image is another really important takeaway. The column, the header was cut off a little bit, but if you just imagine it's a continuation of the same table. So on the left, it's less than 3 years old, ranging from the second to the right is kind of our older kids. If you group the first two columns together and look at the percentage of all of these injuries over this 12-year experience that were in the upper cervical spine, so kind of what we're talking about today, O to C2, that was two-thirds pretty much of those injuries in kids less than 8. And then when you go to the older range of children above, 9 and above to 16, it drops down to about 40%. That kind of gives us an intuitive kind of understanding of why or at least the anatomic understanding of the differences between children and adults is reflected in this difference in kind of prevalence between cervical spine injuries. And that'll become clear after I talk about this slide. So here are the big differences between children and adults anatomically that predispose them to cervical spine injuries. So children have a higher head to body ratio. Their heads are a lot larger relative to their body. There's a nice image on the right depicting that. That becomes less and less true the older they get. Because of the heavier and larger head, the fulcrum, or the area of the spine that bears the most stress, is higher up towards the head in children, in newborns especially, compared to in older kids and in adults. And so because of that, the area of the fulcrum is going to be the area where you're going to see a lot of these injuries. So that's why a lot of the injuries in little babies and little kids are going to be at the craniovertebral junction, definitely in the cervical spine more often than not. And then as you get older, it kind of moves in prevalence a little lower in the spine. The facet joints in babies and in kids are a lot more shallow and horizontal than they are in adults. That if you think about kind of the shapes of those C and C1 joints, those shapes are really important to stability. And when you have shallow and horizontal joints, as opposed to joints that are more vertically oriented, you're going to have a lot more translation that's kind of allowed in that plane. The ligaments don't help with this at all. They're a lot more stretchable in children. So these two things kind of combine to give us a phenomenon we see in kids called pseudosubluxation, where we see anterior, let's say, as an example, translation of C2 on C3 that does not represent a fracture or ligamentous injury. This can be differentiated from, again, a real traumatic subluxation, either by looking at a CT or MRI and seeing an actual fracture or a ligamentous injury, or also on X-ray inflection and extension by seeing how it changes on between those two views. So in pseudo subluxation, there should be full reduction on extension. And then also, you can see on these two lines on this radiograph, the I'm probably not pronouncing this correctly. The Swiss Schuck line posteriorly is a line between the C1 and C3 lamina that you see imaged here. And if the C2 lamina is displaced less than 2 millimeters from this Swiss Schuck line, then it's thought to be pseudosubluxation and not a real subluxation that we need to do something about. To round out this table, other things that are different between kids and adults, the uncinate processes between the vertebral bodies at their lateral aspects are immature or absent in children, depending on how old they are. Vertebral bodies are anteriorly wedged. The nuchal muscles, you can imagine, are a lot weaker, and we kind of talked about that those also contribute some stability. So if those are weaker, there's less stability at this junction. And then the intervertebral discs are a lot more hydrated, and that also means they're more elastic with weaker end plates. So you often see kind of separations from the end plates from the rest of the vertebral body in kids, and you don't see that as much in adults. So a lot of big differences. So briefly, we'll just go over this important kind of guideline or consensus statement from the Pediatric Cervical Spine Clearance Working Group, where they just went over a kind of general algorithm for clearing cervical spine. So, as neurosurgeons, we commonly see these patients present to the hospital in trauma with a cervical collar in place that can either be cleared clinically by either a neurosurgery service, trauma service, the emergency room doctor, um, or can sometimes be more complicated than that if the patient's presenting with some symptoms that may be important. And I highlighted in red the areas in this algorithm where we as neurosurgeons are often consulted to kind of gain our or lend our expertise as to whether or not the cervical collar can be, taken off or what management might need to be pursued. So we'll just kind of briefly go over it. So there's three big groups. There's the comatose group ranging to the nearly intact group. So the comatose group, you're going to want to get it. They recommend at least getting a CT scan in these patients. In adults, CT scans are very, very powerful as far as their ability to clear cervical collar. They're more or less thought to be almost sufficient, really, for clearing a cervical collar in an adult because of the high quality CTs we have and because of those anatomical differences between kids and adults. In kids, because of the ligamentous laxity and the other factors, there's a lot more pure ligamentous injuries that you won't really see on a CT scan per se if they're not dislocated or distracted. So a CT scan is important, but is not sufficient alone to clear a cervical collar. So again, in the comatose patient, even if the CT is normal, it kind of gauge whether clinically, their exam's going to get better if you anticipate that or not within a few days. If it is, then you just repeat it. If they got better, you can try to clear the collar. If it's not, you get an MRI, which is, I think, kind of been our practice here. The MRI will give us much better view as to those ligaments, and we can then think about, their structural contributions and what we need to do. Now, the other extreme is a patient that's pretty much intact, maybe a little bit confusion. And there's where the physical exam kind of becomes really important. So are they presenting with neck pain? Are they presenting with an abnormal head posture, which is how a lot of children with cervical spine injuries present, or difficulty with neck movement? Do they have torticollis? Do they have this kind of classic kind of nexus criteria driven parts to their history, posterior midline neck tenderness, limited range of motion? Or do they have a distracting injury too? That might prevent you from clearing a collar clinically. So if none of this is present, then you can just clear the collar clinically without imaging. If there is some of these components, then it does say that you should get some imaging at this juncture. And they think a radiograph is reasonable, and this kind of depends on the age of the patient. Obviously, limiting radiation is important in these kids if they don't need it. So if that's normal, you can clear the C-spine. If they're exam findings above resolved, or if not, they offer other things that we kind of know about. You can get a Flex X, reevaluate them in 2 weeks, keep the collar on, or you can consult a neurosurgeon or an orthopedic surgeon, and that's where we come in to see if they need an MRI, a CT, and go from there. All right, so now we're going to talk about the actual pattern of injuries you can see in these kids. So the first and most severe is AOD, or atlanto-occipital dislocation. It's twice as frequent in children as in adults because of the factors we mentioned. It's usually really high energy trauma because you got to injure some important ligaments, that takes a lot of force. There's a wide range of presentation. They can either present as they more frequently do in cardiorespiratory arrest or instability hemodynamically that requires resuscitation and stabilization. There's usually extensive neurologic deficits, which often includes cranial nerve deficits because of what we talked about in the first couple of slides. They can also present without deficits, however, and if they're well aligned, and that's where it represents for us a really clear kind of chance to intervene and prevent injury. There are some nice associated radiographic factors that you can see in patients that present with AOD. You can see subarachnoid hemorrhage around the brainstem. You can see that retroclival epidural hemorrhage that we talked about with the stripping of the tectorial membrane off the clivus, the clival dura. And then on the right, I just go over some of the radiographic parameters that were originally investigated using plain film X-rays. And these have just been kind of adjunct decision-making tools that clinicians can use to raise their suspicion for AOD or AO dissociation. When these things or parameters are met, you kind of want to get further imaging and an MRI and have a higher clinical suspicion that something might be unstable. And just generally, AOD is really a clinical diagnosis that can be met with MRI evidence of tectorial membrane, alar ligament disruption, but is also met with the combination of these radiographic parameters in the patient's presentation and instability that's proven at that level. So just to briefly go over these, A and B we'll talk about more specifically in another slide because it's an important one. It's the occipital condyle C1 interval, which is shown to be a really important and sensitive and specific marker. And when this is above 4 millimeters in distance between these two landmarks, you start thinking about the good chance this patient might have instability here or a dislocation or dissociation. The reason that there's a coronal and a lateral sagittal view is because the original paper described measuring these CCI, as it's called, at 4 different points in the sagittal view and then 4 different points in the coronal view, and then kind of averaging them. The second image on the left in the middle is the distance between the basion and the tip of the dens. And so that's the DBI, and if that's greater than 12 millimeters, you start worrying about AOD. On the right is the powers ratio, which is used a lot in adults as well. And that's the ratio of these two measurements. So one, you draw a line from the Bayesian to the anterior aspect of the posterior arch of C1, and then the opistheon to the posterior aspect of the anterior arch of C1. And if you divide those two, and it's less than one, that's normal. If it's greater than one, it's not. If you can imagine that though, what that means. So if it's greater than one, the BC interval or line from the Bayesian to the posterior aspect of C1 is going to be greater than the OA, and that means that there's likely an anterior dislocation or an anterior AOD. This powers ratio, as it's termed, is really not very good at detecting posterior dislocations because the ratio is still going to be normal. However, that's kind of much less likely than an anterior dislocation, so it's still important. In the bottom left of these two columns is another measurement, the BAI, or the distance between the Bayesian and the back of C2. So the PAL is just like the posterior axis line that's drawn to arrive at this measurement. And there are kind of the ranges of normal in children and adult. And then the last one is this ratio you can get called the Son's interspinous ratio. It's the interspinous ratio between C1, C2, and then you divide that by the interspinous distance at C2, 3. So if that's greater than 2.5, then you may have a problem. And then the last thing for AOD is that there is a widely known kind of classification for this that doesn't really get into the management of it as much, but is just a good classification to think about as far as what we see clinically. So type 1 is the most common, especially in children, and that's that anterior dislocation I talked about. It's describing the dislocation from the occiput with respect to the atlas. Um, Type 2 are distraction injuries, and then type 3 involve posterior displacement. So this obviously this classification scheme does not include rotatory dislocations, but it includes the other three. So I kind of mentioned the CCI, and so we'll go into it a little bit more in depth here because it's pretty important relative to the other markers we looked at as far as giving us some insight as to whether this patient has AOD. Again, for patients with this, you want to resuscitate, and this term sandbag is often used to stabilize the craniovertebral junction in patients suspected of having AOD. And what that does is, I guess it's best explained in contrast to a cervical collar. So these children often come in with a cervical collar. If you're suspecting AOD, the cervical collar can often, especially in young children, place a distraction force along the neck. Because they might be larger than the normal kind of distance between the head and the shoulders. So you're distracting there, which is a big kind of no-no in AOD because it can lead to further injuries. So sandbagging is the process of just basically putting sandbags like on either side of the head and neck and taping them often down to the bed, preventing this distraction force that might be dangerous and keeping them safe and stable until we figure out a definitive pathway to management. So back to the CCI, there was a good couple of papers here by Peng et al. And then one by Ravindra et al., which looked at the sensitivity and specificity of all these different radiographic parameters and their ability to detect AOD. So whenever we kind of think about sensitivity and specificity, we think about like what's the gold standard it's comparing it to. In this case, the gold standard diagnosis for AOD is there is no like really one gold standard. So what they kind of compared it to is they considered patients to really have AOD if they fulfilled either one or more of those radiographic criteria we talked about and or had clinical or imaging hallmarks of the syndrome. So territorial membrane damage or cervical medullary junction deficits. And in this study, this was the one by Pang et al. In 2007. You can see comparisons there on the chart on the top. The true false positive and true positive and the false positive give us the sense of the sensitivity and the specificity. On the left is a CCI, and you can see that that's 100% sensitive and 100% specific in this study compared to suboptimal sensitivity specificity in the other kind of range of both radiographic imaging findings like C1, C2 epidural blood, but also the BDI and other measures, which unfortunately in this table they use the authors' names for those radiographic parameters like Woolley, Powers, Harrison, Sun, but that's kind of referring to those different radiographic parameters. So just to make the point, the CCI is a very good radiographic parameter and potentially better than these other ones to use when thinking about AOD. Originally in that paper, they considered greater than 4 millimeters pathologic. However, in subsequent papers, one by Brockmeyer, that CCI measurement decreases with age. So it may be falsely elevated, falsely just with respect to this kind of 4 millimeter cutoff in infants and newborns. And that might give us a subadequate sensitivity specificity in really young patients. So some authors have proposed a kind of higher threshold than 4 millimeters. And you can see that that distance decreases with the older we get. So to round out the slide, traction is contraindicated in AOD, as we talked about. Often these patients are immobilized with a halo vest, which is a more kind of durable external fixation method prior to doing internal fixation. Subsequent studies have looked at kind of what range is considered normal on CT. A lot of, as I mentioned, a lot of these parameters were actually devised on using plain films or X-rays. So this is a really good paper from 2008. in a radiology journal where they looked at a bunch of these patients and without cervical spine injuries, and they compared their radiographic distances of these different things like BDI and the atlantodental interval, and they compared them to what's normal on a CT. And you can see that that's actually pretty different here. So on the right-hand column, here's the ranges on X-ray, and then here's the ranges on CT that they considered normal. So it's often quite a bit less in some cases. And that's posited by the authors to potentially be due to a couple different things, magnification differences between these two imaging modalities, difference in ability to identify osseous landmarks. You know, some of these X-rays can actually be pretty difficult to identify those osseous landmarks, and they can be kind of blurred in children because there's a lot going on with the mouth, the mandible, at the craniovertebral junction that can cloud those things, and then also positioning between these different imaging modalities. So, field is probably moving more towards these CT ranges of normal as opposed to these radiographic plain film ranges of normal. All right, here's the next kind of big injury pattern we see. These are all kind of rare, but they're just different ways that children can present with craniovertebral junction injuries. So translational atlantoaxial or C1-2 subluxation. That is gonna, if there's significant subluxation, it's gonna mean that there's a rupture or the loss of the transverse ligament, termed the TAL here, which can lead to spinal cord compression because, as we talked about, that kind of keeps the dens in place. And if that's not there, the dens might impinge on the spinal cord of the brainstem. Curtis Dickman, spine surgeon from several years ago, came up with the original kind of classification, or one of the important kind of classifications for transverse ligament ruptures. Type 1 is interligament or intraligament, so without involving the bone. That one's thought to be the more unstable of the two because ligaments don't heal very well without surgery. And then type 2 is when it involves the bony articulation there at the medial tubercle of C1. And that can theoretically heal on its own without needing a surgery because bones can heal on their own when they're fractured as opposed to ligaments, is the thought. There's a couple of case series, sorry, in pediatric that's looking at type 2 injuries and their ability to heal without surgery. So this is kind of one of them here. So there's a type 2 transverse ligament rupture in a pediatric patient. It was managed with a halo with subsequent reduction and then ossification on follow-up. And that's this paper by Lowe et al. And you can see really nice healing here at follow-up. Treatment, though, normally, and depends on which author you look at and ranges of, being more aggressive or conservative. A lot of authors do recommend a C1-2 fusion if you're having this issue and having transverse ligament rupture of any sort, even type 2. So it really use your best clinical judgment. The MRI is going to be the best diagnostic modality for this, where you'll actually see the transverse ligament, but the widened ADI, as we kind of talked about, can give us a hint. Next one is instead of translational subluxation at C1-2 is rotatory fixation. This is termed different things in different papers, sometimes used interchangeably. So rotatory fixation is when it's fixed in this rotated pattern. You can also have like rotatory subluxation. So it's just termed different things. It's all kind of talking about the same entity in general. So the etiologies are actually less so trauma and more so infection and different things, and surgeries can cause it as well. But trauma is a not insignificant portion of kids that present here. 80% most of these kids present pretty young, less than 13 years of age. They present with painful torticollis in this kind of classic neck maintained in lateral flexion here that you can see with the chin rotated contralateral to the side of the injury, and this cock robin appearance is kind of what it's called classically. Diagnosis is really going to be the gold standard, and that's was devised by these couple papers by Peng et al. In the early 2000s, is by dynamic CT. So CT with the patient moving in axial rotation and really getting a nice graph, ideally, of the patient's C1, C2 relative kind of angulation there. This is a normal C1, C2 curve. So the x-axis is the rotation of the head with respect to the shoulders. And then C the y-axis is the relative rotation of C1 on C2 with respect to where the head's turned. So this is a normal one. This is kind of outlining what you can see when you get atlantoaxial rotatory fixation. So you see in the worst type, by paying it out, they term type 1, less than like 20% of the full range of motion so you're really just staying at one of these parts of the curve. You're not able to really turn very well because you're fixated in one direction. Um, so this can be diagnostically pretty challenging because of this modality. Actually, in children, there's a lot of physiologic rotation at C1 too, up to 45 degrees. So that's why you can't really diagnose this just based on one still CT of like, let's say 40-degree rotation of C1, C2, because that might be normal. And you also can't really diagnose it if there's a decent loss of facet contact or subluxation there in kids, because that can also be normal. It can be a loss of up to 85% of facet contact at extreme ends of physiologic rotation in children. And so that's why dynamic CTs are so important. Um, this is just kind of a classification criteria used in this, and I don't think it's super useful to go over, but mostly non-operative in these patients. Sometimes managed with traction if they're really fixated at a certain angle to kind of reduce them, followed by external fixation with a cervical collar. And these are kind of the type 1, less severe ones. Internally fixating these kids, especially as a result of trauma, is in the minority, but can be considered when they are chronically disabled with pain, or of course, if they have neurologic deficits, you want to think about decompressing them if needed and fixating them, or if they're type 2 or worse. And that's when you really see anterior posterior subluxation along with rotatory fixation. And that kind of is going to present with more debilitating symptoms. But these patients are actually present not in the acute phase of their trauma often. They present a few days or weeks later with some chronic neck pain. The next one is occipital condyle fracture. Again, very rare in children compared to in adults, but we do see it, and a lot of authors actually think it's pretty underdiagnosed because it doesn't always present with prominent symptoms, and it's can be hard to see on CT. Really, you can see them sometimes only on MRI if they're very fine. They can present with lower cranial nerve or nearby vascular structure injury. And this one, I think it's nice to go over the Anderson and Montesano classification of these condyle fractures. So type 1 on the left is just going to be what's termed the impacted type, just involving the condyle itself without much displacement. Type 2 is the basilar skull type, where the fracture is actually extending into the condyle from the base of the skull. And then type 3 is the avulsion type, where you see this condyle kind of avulse from the base of the skull. And if you remember, the alar ligaments are attaching at these condyles, and the alar ligaments are very important, especially the contralateral one, when we're talking about axial rotation and lateral bending. So these type 3 especially is considered unstable because it typically takes a rotational injury to cause it, and that would mean it has ruptured the contralateral alar ligament and potentially the tectorial ligament as well. So last thing here is cranial nerve injuries are actually present in a third of these patients. So it's actually pretty common to present with cranial nerve injuries. Surgically, again, minority need surgery. Those that have vascular compromise are going to need it potentially. Those with a persistent instability following a trial of non-operative management may need surgery. And those obviously with AOD doesn't need much more explanation, may need surgery or will need surgery. All right. Next one is atlas fractures. So fractures of C1 in adults, often also termed Jefferson fractures. In children, it's again very rare, but you can see them. An important discussion point when talking about atlas and then axis fractures is synchondroses, or these areas in the atlas, especially in younger children, less than 10, often less than 5, where you see that these cartilaginous zones that are paired with like ossification centers are still open and not fused or ossified. And so a couple of things to mention is number one, you don't want to confuse one of these synchondroses with a fracture on a CT. So often that's differentiated by really nice cortication at the ends of these synchondroses compared to a fracture, which doesn't have that. It'll have a break in the bone without a cortical edge, or a corticated edge, rather. Um, but you can, even though these are not fractures, you can get fractures or ruptures of these synchondroses where they're displaced here, and that does need consideration of further management in children. So there's the posterior synchondrosis at C1, which fuses by age 5, and you'll get ranges of ages here, but age 5 is one. And then anteriorly, these synchondroses fuse by age 7. Again, it's extremely rare to get a fracture here prior to the teenage years because these synchondroses are more able to, they have more laxity, and so it prevents fracture. When you get to the teenage years, these are ossified, and we think of them more as adults as far as their anatomy and predisposition to injury. Beware of pseudo spread, which is where you can get lateral translation of C1 lateral masses on C2 that can be normal in children. And so this can be worrisome in adults because we worry about like transverse ligament rupture, but you can actually get pretty decent pseudo spread, as it's termed, in children, and it doesn't mean they have a fracture. And this is just like kind of one example of a patient with a synchondrosis rupture at C1 from a traumatic etiology. And you can see that on an MRI with some stir signal there. And that was treated conservatively, and the patient ossified or fused across that segment. So the next one is dense fractures. Again, similar idea here. You have these synchondroses. They fuse by a certain age here, the thought around age 8. Which can mimic a fracture on a CT, and you don't want to confuse them. Majority of these are conservatively managed. You want to fuse them when they're pretty displaced, when they're comminuted, when the ADI is pretty high, or they have some deficit. C2 pars fractures are very rare in children. They're usually don't happen because of these synchondroses, and you don't want to confuse them again. And you only want to fuse them when they're displaced. So we won't get into them too much because they're so rare in children, but kind of the similar idea from the last two slides. Wrapping up this variant anatomy part, there's a lot of other things you can see in kids that can mimic fractures but are not fractures. And a good example of that is an condylus tertius, where you can see a corticated kind of third condyle, as it's termed here. And the corticated part is what lets you know it's not a fracture. The os odontoideum is thought to either be congenital or from a prior dense fracture. And this one is more important. I highlighted in red because these patients often present with mobility and may need fusion from pain. And then just briefly, there's a couple constructs that many constructs people use to actually fuse these patients. At C1-2, the classic is this bone and cable Sontag style fusion where you put a wire across C1-2. You can put these screws across the joint, which can be technically challenging, and these have really high rates of fusion. And then OA fusion constructs, basically you can do these transarticular screws with these laminar wiring and just use a plate to connect to the occiput here. This is just a case that we saw in clinic of a patient with os odontoideum with pretty significant right-left movement on CT head here, and then CTC spine here. You can see a big difference. Patient had symptoms of pain and ended up going for a fusion because of this instability. Last kind of big teaching points here, and I'll wrap up in two slides, is that when you fuse O to C2, you can get a really big decrease in flexion and extension up to 14%. And then lateral rotation, you can get up to a 30-degree decrease if you believe these studies here in lateral rotation. And that can be pretty impactful with regard to driving because you need to turn up to like 42 degrees to the right and 35 degrees to the left, as seen in this study, for example. And if you're losing 30 degrees of your lateral rotation in someone you fused, you got to think about their ability to drive after that. So it can be important when counseling these patients on what the impact of OC and C1-2 fusions can be. And that's it for me. So I'm happy to take any questions. I know I kind of ran up to the end of the time here.
Gabe, that was a fantastic overview of craniocervical trauma in children. Really comprehensive, really nicely done. We have a lot of non-surgeons that attend grand rounds. If you had to distill three lessons that you've learned taking care of children that make them different than analogous or similar injuries in adults for the audience, what would those three things be?
Yeah, I would say the three things to really keep in mind with children is one that they can present more subtly. And it can be harder to identify injuries in these kids, especially cervical spine injuries, because of how they present. They may just present with lack of ability to turn their neck fully, and be preferencing kind of one side. And you want to have a high index of suspicion for having a cervical spine injury in a patient that presents from a traumatic mechanism of injury. I would say two is when working up these patients, it's important to know their anatomic variants because they can have things that can mimic fractures that are not fractures. I think having a good radiologist and a good neurosurgical team that can assist with really identifying what might be something that needs to be managed and what might be kind of a variant of normal. And I think the third thing is that the majority of these patients, even with injuries, can often be managed conservatively and do pretty well. And I think that's a difference between kids and adults.
Yeah, I totally agree. I think the third thing is probably of all of them, they're super important lessons that you just distilled for everyone. But for our audience who are non-surgeons, one is that there are things that we will tolerate conservative management for in a child that we would not in an adult. And the second, I just want to make a plug for our neurology colleagues, our PM&R colleagues. If you see an Oz, send all those Oz's to neurosurgery, Oz odentoideum. Those are considered unstable unstable findings. And so if you guys see any of those, don't think of those as normal variants. Think of those as something that, Jenny Roniker needs to see in clinic. So thanks, everybody.